Welcome, everyone. We are so glad to see you all in this space as we move into talking about resistance to family engagement. That's our topic for today. So I just want to make sure that you all are in the right room. We are finding the we, exploring resistance to family engagement. And so I hope that you all have had and have enjoyed the summit up until this point. And so we're really excited again to have you all in this space. I am not going to prolong the time. I want to give our presenter all of the time that she needs to discuss this very important topic. But I just want to make sure that everybody can hear and see the screen. So if you in the chat could just let us know, just let us know you're there because we can't see you all. So if you can just put some chats in and let us know it's good, it's good. All right. I see Rachel and Bonnie and Skip. Way awesome. Deborah, thank you all. All right. All good. Great. So I am going to move out of the way. I'm so excited to be able to hand the floor over to Carol Dickey, our presenter for this session. So over to you, Carol.
Thank you so much, Gia. Welcome, everyone. Thank you for taking the time to be here today. I am Carol Dickey, and among other things, I am a parent of 5 children, some of whom, through their earliest experiences in life, introduced me to an array of services and supports for children who live with complex behavioral, emotional, and mental health conditions and developmental disabilities. It has been a long journey, and we're making it through. We're living the experience. And I will be forever grateful to the people who have helped us along the way. I am forever changed by the systems which have affected us in ways that are still unfolding. It is that which drives me to this work. And I am so fortunate to live in a state where there is a strong commitment to system of care values, where the hard conversations are happening and the work is being done. Um, Among the groups with which I participate, one of the most frequent topics of conversation is how to bring family members to the table, to committees, to advisory councils and work groups. And I've seen an incredible expenditure of creativity and effort really in service of that goal. And still, it remains an issue which suggests, at least to me, that there may be something more at play. I really believe that resistance is a multidimensional, deeply rooted phenomenon that I have the privilege of exploring out loud in our time together today. There is a lot of guidance that you may be aware of, published in various places on how to invite families into this work, how to set the table. I'm not going to repeat that here. I'm going to explore what I believe are the deeper roots of resistance, how they may show up in your interactions with family members, and how groups might work together courageously to overcome them. And I'm here representing the family experience and the family voice. My observations, my comments are reflective of conversations I've had with now over 300 parents and caregivers. And it's really been extraordinary to hear of their experiences and to learn about what I've come to know as our common experience. Well, every journey is unique, every story is unique. The universal elements are absolutely striking. They can't be missed, and I think they shouldn't be ignored. So I'm drawing today on that perspective, the shared experiences of families. And you may or may not find resonance with what I have to offer. You may find some of what I'll say provocative. However it lands, though, I hope to encourage deeper thought and maybe a different way of seeing family engagement in system of care work. And I'd like to just take a second to introduce the amazing agency for which I work, Oregon Family Support Network. We serve families caring for children who experience complex behavioral, emotional, and mental health conditions through one-to-one peer support, as well as support groups, a warm line, training, advocacy. We meet families where they are, helping them to draw on their identified strengths and their expressed traditions as they make their way. As an organization, we believe that every family deserves to be heard and understood. And it is with that vision that we work to support, educate, advocate with, and empower families like our own. As we move through our time together today, I'm going to engage you in a series of questions. Questions for reflection, but questions that I hope you'll take with you to pose within your groups. Some of them may be difficult to answer out loud, and that's the point. I'd also just really like to make transparent some of the assumptions which underlie this presentation. I think in this work, it is always essential to separate the people from the systems. And while people operate within the cultural norms and standards imposed of the system, they come to their respective positions with a desire to do well and to do good for the individuals and families they serve. Systems are beholden to the cultural norms within which they were constructed. Group standards are necessary. They give us a template for how to think and for what to expect. But there's a top down mental model that most of us have internalized. Our systems are hierarchical, they are rooted in and perpetuated by institutional oppression. And although the system of care framework has emphasized family and youth driven care since its inception, most of us are not quite there. And truly incorporating families as partners represents a totally different way of doing business. It represents change, and resistance, implicit or explicit, is a part of change. And it can also be a way of keeping us stuck. And then finally, the outcome of successful system of care work will be evident, will be felt by youth and families at the service level. And that's where we'll start today. And also, just a note, we often speak of family and youth voice or family and youth participation as if they're one, but the experiences of caregivers and youth can be very different and should, I believe, be honored as such. So while I may include youth in some of my examples, I'm speaking today specifically from the perspective of parents and caregivers. Over the last 4 decades, the system of care framework has delivered a number of important, innovations in how systems are structured and in understanding the inputs that contribute to an optimal service array. There is no doubt that youth and families have benefited from the availability of care coordination, case management, community-based care, in-home services, wraparound, and peer support. I think it is unequivocal that the systems which serve children are better today than they were 40 years ago when this movement started. And still, according to the Centers for Disease Control and Prevention, at least 3/4 of children and youth who experience serious emotional disturbance don't receive adequate treatment. And this has been attributed largely to structural, financial, and personal barriers, including the experience of stigma, which can affect care seeking, and also the way in which services are delivered, the interface between families and systems. This is what families are facing. Systems which serve youth are better today than they were 40 years ago. I think it bears repeating, and it's a work in progress. Evaluation of the system of care approach supports positive outcomes at the system level. At the child level, while studies have pointed to outcomes like a decrease in out of home placements, improvement in school performance, less juvenile justice involvement, and a reduction in behavioral and emotional symptoms, the studies are few. And the effect sizes, that is, the practical significance of the results, where reported, are small. What that means is that the peer-reviewed research is hopeful. It's suggestive, but not at all robust concerning outcomes at the child level, and it's almost completely lacking where it concerns family-level outcomes. And this is key. Children do not exist as separate from their families. Systems that care for children must consider and support the needs of families. Also, the point has been made in both public reports and by researchers that the relationship between the system level and the practice level is not clear. And why is this important? It's because families meet the system at the service level. That is the system of care that we know. The words that you see on this slide represent the experiences of 112 caregivers who responded to a request to provide just one word describing their experiences in the child serving systems. And you don't have to see the image in full to notice a theme. And it's important for me to pause here and to say that the words helpful, inclusive, and relief are included on this slide. They're very small. They represent about 2% of responses. And this demonstrates the disconnect between the ideals, which are often discussed around system of care tables, and what families endure in real time at the service level. At the service level, a lot of times there isn't collaboration or partnership. The family voice is sometimes actively, even aggressively discouraged. Parents who advocate for the needs of their children may be dismissed or labeled or pathologized or worse. So, when they're asked to participate on an advisory committee, some caregivers may be reluctant because of the way they know the system, because of their direct experience at the service level. And this is not a small issue. This is where the family voice first meets resistance, and it's powerful. It denies us of agency. It denies us the ability to participate in our children's care, to express what our families need, and to have those needs addressed, which by definition is a form of structural violence, a form of violence wherein social structures harm people by preventing them from meeting basic needs. Other examples of this with which we're more familiar that include racism, sexism, ageism, the isms. Structural violence has been associated with social determinants of health, with disparities in access and outcomes. And it is said to be greater in scope and implication than any other type of violence. It's insidious and it grows unchecked because it's embedded within our social structures. In other words, the experiences which families describe at the service level are largely overlooked because they've been normalized. And within the context of this discussion, this is not an us versus them phenomenon. It's a part of the social fabric within which our systems exist. It affects us all and informs the way we think when we consider family engagement in system of care work. Family engagement, true engagement, is a result of inclusion. Inclusion is the we. It's a felt sense of belonging, of having shared values. people can be themselves. There isn't a need for assimilation or hiding parts of ourselves to fit in. Differences are welcomed, uniqueness is valued. Think about whether you believe the families you work with feel included at your system of care tables. Do they feel a sense of belonging, a part of the we? Do you feel belonging? Many of the questions I'll pose today really apply across the board. Um, I've had the opportunity to think about this, about finding the we for a very long time. I've long participated in groups in which my experience was different from or complementary to the majority in the room. Early in my career, I was often the only woman at the table in a group of men. I was often the only non physician in a group of physicians. And today I participate in spaces where I'm one of only a few family members of children who experience complex needs and challenges in a group of people who are generally not parents of children with such needs. This experience, though, this is distinct. It's different from the ones that came before. As the only woman, I sometimes felt objectified, but I knew that my expertise was valued. As the only non physician, I sometimes felt different, but I was there because my specific area of content knowledge was needed. The fact that what I brought to the table was valued gave me a sense of membership in the group. Mind you, it wasn't optimal. It wasn't deep belonging. My differences were apparent, and I wasn't necessarily invited to play golf after the meeting, but it was clear that my input was meaningful. My input was valued. I was not asked to participate in those groups simply because I was a woman or ever because of the fact that I was not a medical doctor. Family members, though, are asked to participate in system of care groups only because they're family members, and it's not always clear why or that what we bring is valued. And we've learned at the service level that our input is not valued, that we need to be quiet and compliant. So, the first question I would pose for your reflection is, why are family members at the table? Why are family members at the table? And there are a lot of ways to answer this question. Before I go there, I just will plant the seed that the opposite of belonging is othering. So, one of the simplest and most straightforward answers to the question, why are family members at the table, is because there's a policy or a protocol or a contract line that requires it. Your group must include representatives from specific sectors with certain job titles and with lived experience. In the case of system of care work, those policies are derived from a philosophy which extends that the most optimal services are family and youth driven, and that family and youth should be full partners at the system level, in policy, governance, system design and implementation, evaluation, quality assurance. What this says is that families, the family experience, the expertise of the family experience is an important ingredient in getting it right. So, what does that really mean to you and your group? Do you believe that? Do you value family experience as expertise, as an essential ingredient in system change? This is, I think, an individual question and a group level question. And if there are people in your groups for whom the answer is no, family input is not essential, and there may be, then how does that affect the group dynamic? How does that affect implicitly or explicitly engagement and inclusion? The policy or contract line requires only that family members be recruited to the table. The philosophical framework suggests the why. And there's a world of difference between the act of recruitment and the concepts of inclusion and engagement. To include family members, as I've suggested, is to value their input. To engage them is to involve them meaningfully. Um, Engagement is also an outcome. It's a state of mind that results from the feeling of being included. It's expressed in an applied commitment to the work, willingness to do the work, eagerness, creativity. Um, Meaningful engagement, meaningful family engagement. This is a phrase that I hear frequently, but it's a phrase really without a meaningful definition. And there's a broad cross-disciplinary literature regarding the benefits of family engagement. And within that array, engagement is contextualized very differently from compliance with a prescribed treatment protocol to full partnership in decision making. Given that, how you might characterize engagement within your groups has to do with your answer to the question, why are family members at the table? And this could really be a presentation in itself. I'm not going to make it that. Instead, I'm going to focus on the word meaningful and suggest maybe we don't need it at all. Inclusion and engagement are constructs which can be operationalized, they can be defined within a given context and measured, and they can also be evaluated qualitatively. Meaningful participation is impounded in both inclusion and engagement. And just like any other member of the group, if families feel a sense of inclusion, a sense of belonging, and their input is valued, then it is necessarily meaningful to both the individual and the group. And within system of care work, it will contribute to the group's understanding of the functioning of systems such that those systems might be optimized. So, again, why are family members at the table? And for that matter, why is anyone at the table? Meaningful inclusion and engagement are not exclusive to families. In order for a group to be successful, its members must be engaged. Um, it would be an interesting exercise at the start of the meeting, and this is something that we've discussed in one of the system of care groups with which I participate. It would be interesting to ask each member of your group why they participate. For some, the answer might be, "It's a part of my job. It was on my calendar when I started the job." That's an honest answer. That person is probably not likely to be all that engaged, which is important to know. And then a follow-up might be, "What is your commitment to the work?" And for some, the answer will be a commitment of time, an hour to a month at a meeting. And again, that's an honest answer. It may not be optimal for the purposes of the work, but it's honest and important to call into the room. For those, and this really applies to anyone who don't feel the commitment, there really can't be true engagement. And might that change with a deeper understanding of the cause of the work or with a greater sense of inclusion beyond the calendar appointment? Maybe. And this is important because if systems are going to work for youth and families, those who represent the institutions of which the system is comprised need to be engaged in the work. We all need to feel included in the group's purpose. The diversity and inclusion literature suggests that one of the most powerful tools of inclusion is getting to know one another and discovering our similarities as human beings. So, digging a little deeper along this line and maybe entering into the protected space of vulnerability, members could be asked to share why they do the work they do beyond system of care, what brought them to the work. We often don't do these things in meetings because of time constraints, and we'll talk more about that in a minute. Sometimes we don't do it because it isn't what we're used to. And sometimes it just feels really uncomfortable, but we all have a story. We all come with a story. And I find that so many people who enter the helping professions were led by really profound experiences. And it is that which connects us, which points to our sameness, which um, plants the seeds of inclusion. Getting to know people beyond our assumptions, beyond our fear, um, is inclusion. And we've all had some kind of journey. When we feel included, we're more likely to be engaged. And these are not static concepts. Individuals can become more engaged in their groups over time. The system of care framework gives us this opportunity for dynamicity, the opportunity to create, obviously within financial constraints and other boundaries, an array of services and supports which best meets the needs of those for whom the system exists. And one of the most important attributes of the framework is its mutability. One description suggests that system of care is a cluster of organizational change strategies. We have this opportunity through the framework to create change, to expand thinking, to understand deeply from multiple perspectives, to redefine policy and process, and ultimately to affect service level outcomes. It's really exciting when you think about it. And then we go back to the same old dusty tables with the well worn rut of this is how we've always done it. And we don't necessarily see or attend to the fact that the rut has been worn by traditions of systemic subordination, marginalization, othering, structural violence. There is no requirement that things be done in the same old way. It's what we know. The rut is really comfortable, and change is hard, and change engenders resistance. So, let me give just an example of the rut. One of the things that family members are often asked to do is tell stories. We talk about our experiences at the service level. We talk about our experiences with our children. We sometimes speak of the absolute worst moments of our lives. It's raw, it's real. And then after our 10 minutes are up, the agenda moves on. That is resistance to engagement. The content, the substance of the experiences we share, those words a few slides back, which characterize our experience, don't stay in the room. They're subordinated to the next item on the agenda. Is that intentional? Of course not. Of course not. It's just how we've been conditioned. It's the way we do it. Consider, though, the impact, the message it sends. It isn't one of inclusion or even of mattering. Another example, not long ago, I was in a system of care meeting in which a parent, an incredible advocate and leader, made a comment. She told of an experience, after which the facilitator, a person long involved in this work and an extraordinary ally, thanked her for her comments and moved the agenda forward. That's just the way it's done. And then all of a sudden, her Zoom hand came back up. And in a moment that would have been really well served by a tension building musical accompaniment, she unmuted and said, "But wait, what are you going to do about it? I want to know how the problem I just raised will be addressed." And the room went silent. And in that moment, I believe everyone was patently aware of the problem. No one knew what to say. Families are storytellers. The information we share is not held in the room. It never makes its way onto the agenda. As it has been contextualized within the rut, the experience of the expertise of the family experience is a slogan. It's a really deep rut we're in. And what are we going to do about it? That, I believe, is system of care work. How will you keep the family experience in the room and at the fore? And do you believe you need to? Questions to take with you. Do you believe you need to? The rut is of the historical cultural norms which gave rise to the systems within which many of us have been steeped through experience, through education, more experience, and through organizational culture. These systems were never conceived to be inclusive. They're systems of oppression. And until we can pull ourselves out of the rut, they'll remain so. The rut includes us and them thinking, in groups and out groups, top down processes, stereotypes, implicit bias, and sometimes the frank discrimination that comes with stigmatization. The rut is beholden to expectations and prescriptive timeframes, which are rigid and which are often unrealistic given the work. This is resistance. Time can stand in the way of inclusion. That's a societal norm. An agenda can stand in the way of inclusion. That is how systemic disenfranchisement shows up at a micro level. This is not accidental. The system was built to perpetuate itself. So we are all of the system. Um, I'll just break some of this down a little bit. A couple of slides ago, I mentioned that the opposite of belonging was othering. Ironically, one of the things we all have in common is our experience of feeling othered. And if you can't think of a current example, take yourself back to middle school. Grouping people is a social psychological phenomenon. We develop an identity based on the groups to which we belong. Again, think about middle school. And of course, a lot of this happens beneath consciousness. It's automatic. It's a part of us. We need other in order to understand self. Generally speaking, though, othering emphasizes differences and overlooks similarities. And in this way, it can function to reinforce discrimination. It can be a way of legitimizing or maintaining a given power structure or hierarchy. The rut. We're more inclined to help people whom we perceive to be like us. Think about that. Think about the ways in which you coalesce and form groups at work or in other aspects of your life.
Hey,
Othering
Carol.
really, yeah,
Carol, I'm sorry. I wanted to know, did you want to ask questions as you go through, or did you want me to hold those to the end? Because you do have a question in the Q&A section.
I would be happy to take a question.
Okay, and I put it on the screen. I know you can't see on your end, but it says, how can we push the system to have meetings outside of the 8 to 5 business hour?
That's a question for your individual group. I think it's hard because so many people do this work as a part of their day jobs. And if that is preventing someone from being involved in the group, from being included in the work, that is a discussion that needs to be had. And if that conversation is not being had, if it's not even within the realm of possibility, um, that says a lot, I think. I'm really fortunate in that the groups with which I participate and the groups in general in my state meet at all different times. It is possible. So, thank you for the question. That's a great question.
Thank you. And I was going to also acknowledge just a lot of good feedback in the chat so far about family engagement. We won't have time to read it all, but I just wanted to acknowledge that folks are resonating with what you're saying. So thank you.
Thank you. Thank you for sharing that. I'm glad. I cannot see you all. I can't see anybody. I can't even see myself. So I feel a little bit like I'm in a cave. So I appreciate that feedback. Um, so othering really signals the way that we regard certain people or groups. It effectively creates a separation, a distance between us and them, and it is antithetical to collaborative work. Our groups are socially constructed. We have a choice. The public health literature suggests that even more than reinforcing, othering derives from, it comes from discriminatory practices. It has been identified as a stressor that impacts health and well-being, and it contributes to health disparities. The person or the group being othered experiences a process of marginalization, of disempowerment, of social exclusion. Othering is not at all inconsequential. When you think about your system of care groups, is there othering? How does it show up? I would offer that not having an avenue for conducting meetings after typical business hours may be a form of othering. And my guess really is that this may be a difficult question to answer and for some difficult to answer out loud. But let's just take a look. Here's a list in no particular order of some of the people who might be a part of a system of care advisory group, let's say. And while this is drawn from some of the groups I know, it's not a description of any particular group, it's approximate. This is really just meant to be representative. But if you take a moment to look at the list, you see positional differences, that is, differences in titles. You see status differences. I would guess that not all of these people sit around the same lunch table. You see sector differences, organizational differences in terms of both size and purpose. There are functional differences, geographical differences. And yet, when you're using descriptive language to refer to the complement of people around the table, it sometimes looks more like this. Even with all the differences, the people who do not parent children who experience complex conditions are called professionals. And this happens to be one of my personal pet peeves, so I talk about it a lot. Us and them, us and other, professionals and less than professionals. Does this happen intentionally? No, I don't think so. It is a microaggression for sure, but I believe it represents the societal stigma around mental health layered on top of the ways that many of us have been conditioned to think of parenting, of our children's behaviors as mirrors of our abilities. So I do not think it's intentional. And I know that it takes intention to change. And change is hard, and change engenders resistance. And sometimes I believe that resistance is reinforced because there is no intention to harm. And the impact is not necessarily seen or known because the behavior has been normalized and it matters. Language, language has the power to other people and groups in big ways. The most extreme example of this is hate speech. And within healthcare, there's a long and ugly history of pejorative language used to refer to service users. And while research shows that the propensity for pejorative language is trending downward, it's there and it's extended to families. Um, I've exchanged experiences with several parents, about a handful, who have heard providers in a congregate care setting talking about them prior to meeting with them. This is an extreme example. It's not extreme in that it happens, it is unusual in that it was heard. The significance, though, I think, is that the attitudes that underlie the language enter the spaces even where the language isn't used. There's a lot of guidance on person-first language and being more aware of the origins and impact of the terms we use. One of the more insidious ways that, othering shows up in language is in commonly used words or phrases that objectify the individual or family. Case management. People are not cases. Warm handoff. The intention is to create a bridge between services. That's a beautiful idea. But where's the person? Where are the people? Where's the warmth? Intervention, which implies doing to as opposed to doing with. In the frame of the person-centered care initiatives, which came about in the 1960s, intervention is an oxymoronic concept. The list goes on. These are subtle ways, and we all use these words. Families, providers, administrators, we all use these words. They're subtle ways in which deeply rooted norms communicate to people, to service users, that they are less than. By these terms, we are objects. Our system sometimes resists engagement by dehumanizing. dehumanization being a primary tool of oppression, of othering. And as I said, we all use these words. We've all internalized the hierarchical order upon which these words are based. And families are cases, and cases are objects. Can we change all of this overnight? No, of course not. But we can become aware of it, aware of the impact, and apply intent to choosing differently, to begin to think differently. The bottom line is that words matter. Language is also socially constructed. We have a choice. What if members of your system of care communities decided to identify according to the experience or expertise each person brings? I represent rural health centers. I represent the Department of Education. I represent a payer. I represent the provider experience. I represent the family voice. This not only levels the table, but it's informative. Take a second to step back and ask yourself what function communicating arbitrary divisions like professional and family members serves. What is the function to you personally? What is the function to the group? And there can be a lot of answers to this as well, but I imagine for many, it's habit, it's conditioning. Language is a powerful tool. It can draw us closer together or drive us farther apart. The words we use are a part of our experience. They contribute to or detract from the psychological safety which is necessary to feel a sense of inclusion, to feel belonging. Which is a good segue, I think, into top-down processes. We've already established that families learn about system of care at the service level, where for many, power, control, and coercion are the norm. And where that is the experience, it becomes also the expectation. And I would also just like to acknowledge that I'm generalizing. I know that there are many service providers and groups who work with families to truly understand their experiences and to leverage their strengths in a caring relational environment. That fact should not be ignored. It should really be held up as an example of the types of relationships that are possible at the service level. I believe that too is fundamental to system of care work. And according to the several hundred families with whom I've spoken, the service level is still driven predominantly by its roots. And so, as I said, where that is the experience, it becomes the expectation. How do you create an inclusive container where there may be a fundamental lack of trust? It's hard. This is relationship building. It's a process. It may feel like a process of repair. It is. So, questions to think about, to ponder in reflection as you evaluate your groups. What are the rules of the game within your system of care spaces? How do you conduct business, make decisions? How do you choose which issues you'll address and in what order? How do you set the expectations for your group? Are the conversations that you have with families separate from the larger group? And do they want that? Or is it a form of distancing? And here's a big one, and there's a lot, I think, around this. When you decide to address an issue, do you consider at the top how youth and families will ultimately be affected? Do you ask that question out loud and think it all the way through as a group? Or is it more like drawing the lines and making connections after the fact? We clearly need strong systems to provide services and support, but are your priorities the ways in which you operate centering systems or families? That's a big old messy question, and sometimes those will be the same thing, not always. This is not just about inclusivity in meeting spaces, but inclusivity in purpose. What or whom do you see first as you approach the work? And I would offer that seeing the needs of families first, asking families what they need, will necessarily drive strong systems. Seeing systems first will result in change, and sometimes that change will benefit families. But it really serves to reinforce the status quo. And there are 40 years of evidence which support this. So, how do you decide which decisions to make and with whom? And are decisions already made before the group meets? Hierarchies, for their stability, require certain behavior patterns from their members. What do your group norms and behaviors and behind the scenes activities communicate about power and control? Again, these questions are for pondering in your quiet time, but also for discussing out loud within your groups. And all of it really goes back to the question, why are family members at the table? Do you value the expertise they offer in your decision making process? Might you be demonstrating resistance to family engagement by actively or passively serving the rut? Or are you creating a container that centers the needs of youth and families and in which there is psychological safety, inclusion, belonging? And how do you know? We think about safe spaces as those in which everyone feels they can speak up, where everyone feels they can take risks or make mistakes without fear of retaliation, where people can express differences of opinion and disagree freely. It may be an uphill climb for families to feel safety even when the group is making every attempt. Why? Because they've learned from their experiences at the service level that they shouldn't speak up. Their experiences may be a barrier to participation in system of care groups. The fear of retaliation is very real for families. I'd like to see that come into the room and stay for the what are we going to do about it part. Not long ago, I spoke with a parent, a mom, who had been on a local system of care advisory committee for some time. And she told me that she had stepped down because she felt as if bringing her experience into the room was resulting in retaliation. More than once, she had been denied access to service for a service for which her child qualified. And it wasn't really all that blatant. It wasn't denied outright. She was made to jump through a few hoops, and then she was put on a waiting list that would take until rapture to exhaust. Well, she saw others in her community being served in real time. Her belief was that the services had been withheld because of something she had shared within a system of care space. And you can challenge her belief, you can other her, but that's not the point. Well, and it's precisely the point. It's a lot of points. For this discussion, it's not about whether the denial of service was related to her sharing of an experience, though that speaks to power. It's about the fact that she believed it was possible. That speaks to the lack of psychological safety that she was offered in the space, the origins of which are so deep. And I tell this story because she's not alone. This is not a single story. So, as you consider the way your group functions, ask how it's working for you and whether it's working for everyone. How does power show up within your groups? Having a child or children who live with complex challenges can be incredibly isolating. And it's isolating in part because it requires all of you, but also because in our society we have pretty rigid standards and expectations about how children should act and somewhat narrow uninformed views around behavioral health conditions and developmental disabilities. People notice what might feel different about your child and your family. They don't understand the behavior they see. And you may not understand the behavior you see, but friends, family, neighbors begin to distance themselves, us and other. And the same thing happens within systems. I remember when my son was in first grade and behavioral symptoms, which we had been bringing to providers since he came to us through foster care at the age of 22 months, started to escalate. And without a lot of curiosity around it, the school labeled him as disruptive. And they labeled him as a lot of things, but I'll stop there. And we were new to the area at the time, and so we sought the help of a pediatrician who we hoped might serve as a guide to other services, as a referral source. And after spending 15 minutes with our son at the age of 6, she labeled him out loud a bad boy and suggested that his life path was unpromising. I, as a parent who wondered what on earth we were doing wrong, apologized all over the place. I apologized sometimes instead of asking questions, a lot of times instead of asking questions. And then at some point, it became clear that our son would need more than traditional outpatient therapy. And as we began to make our way through more intensive services, we realized that we were under scrutiny and we were being evaluated and reduced by assumption and judgment. And by that time, I had stopped apologizing and I bit back. And that earned me some labels. And in sharing these experiences about our family, I've just described each of the levels of stigma: public, institutional, self, and family. Every parent feels isolated and alone. We feel like we're the only ones until we meet each other. And then we discover that these experiences, the labeling, which is really a toned down way of saying name calling, othering, judgment, and assumption, those experiences are universal. Every single family speaks of them. And where we are held so separately, there can be no we. It's only us and them. And as families, we are fighting, sometimes quite literally, for our lives. That is the family experience. It doesn't show up on the agenda. Systems rooted in oppression perpetuate themselves. They resist inclusion by design. Stigma is one of the most insidious forms of oppression, of resistance to inclusion. One way to think about it is that self-stigma and family stigma are how societal attitudes are internalized by the individual. Public and institutional stigma are how those attitudes are enacted by systems and by the people who exist in and have been conditioned within them. Stigma comes into system of care spaces because it can't not. And well, research indicates that behavioral and mental health professionals are less likely to stigmatize than the population in general. They still do. It's in all of our spaces. When family members join a system of care group, they bring that. And as you sit at the table together, do you contribute to it? Do you reinforce it? Again, a question for individual reflection, but one that I also believe needs to be spoken out loud. The stereotypes from which stigma emerges are socially constructed. We have a choice. They occur between and among people, and as such, we can change them. It takes intention, it takes effort, and first, it takes awareness. Stigma comprises stereotyping, prejudice, and discrimination. It takes all three. Stereotypes, we know, are not intrinsically a bad or harmful thing. They're a way of structuring knowledge, right? They reflect a particular worldview. We all use stereotypes and labels. They may or may not be valid, but they're a representation of how we think, how we've been conditioned to think. And that's where the conversation starts. When you sit across from me, what judgments are you making of me? What judgments am I making of you and why? What in my experience is leading me to make those conclusions without knowing you? And Can I learn about you? Can I get to know you and challenge those assumptions, those judgments? Can I replace them? Inclusion, the we, is not about gathering in a common space. We need to meet each other. One of the funnest, and I've been talking about this a lot lately too, one of the funnest, I think, and most effective ways of discovering the implicit bias that lives within us all and gives rise to stereotypes is by playing the game Two Truths and a Lie. If you've typified someone according to appearance, job title, who they parent, who they love, a comment they once made, where they live, the background on their Zoom screen, this game is an invitation to let that person step out of the box you've put them in. It's a great exercise in perspective taking for every member of the group. The unraveling of a stereotype is an intentional process. So the second element in stigma, prejudice, is affective. It's how we feel. The stereotype is the difference we see. When we begin to assign an emotion to that difference, fear, disgust, anger, antipathy, that's prejudice, bias against a person or a group of people because of a perceived difference. If you actively challenge your stereotype, change the lens through which you judge someone, bias doesn't happen as readily. And then discrimination is the behavior that follows the emotion. I don't want those people in my group. Stigmatization requires all three. Do you see discrimination within your groups? How do you address or evaluate stigma? And if you're not asking these questions, it's a silent participant. You're in the rut. To truly avoid resistance and establish inclusion, a sense of we, these conversations, this sort of group evaluation and individual perspective taking is necessary, and it's hard. As an approach, system of care is built for adaptation, growth, change, and it is held within the rut of oppressive norms. So, how comfortable are you where you are? Are you best served by the status quo? Families most definitely are not. But what is the impetus for change? It goes back to the original question. Beyond the stipulation of policy, why are family members at the table? Do we bring a specialized expertise as service users, an expertise which is essential to creating and maintaining an optimal service array? And if what we have isn't essential, is it important? Important enough to address the hard questions, to bring our actual experiences into the room, to see them as more than single stories or idiosyncratic events? Important enough to set aside judgments which are conditioned, and to become curious enough to understand the issues that we've expressed in a way that can lead to an inclusive conversation, incorporating all perspectives and the richness of all of the expertise in the room. I believe that when these issues, when service level issues are addressed, every part of the system will function more effectively because if you're addressing the needs of families, you must attend to the needs of providers and all of those who work on the front line. And to attend to the needs of the front line, you have to address the needs of those who support them, which requires also addressing the needs of the provider agencies they work within which they work, and on and on. And this is not a unique proposition. It's parallel to the theory that if you elevate the most oppressed in our society, all of society benefits. The system of care approach is elegant, I think, visionary in its expression of how things ought to be, how systems might function, could function. The approach believes that family and youth voices are essential. Can you conceive of a work table that looks more like this, which includes family and youth as full partners in imagining the systems and how systems should be in supporting their express needs, the needs for which the system exists? That's a big question. And I think the answer, at least the necessity to consider these questions, can be seen in part in fact that in the fact that some of these questions, especially those which concern behavior at the service level, have been documented for 40 years. They're the same conversations that Jane Nitzer reported in her landmark study, which gave rise to the system of care framework. In the last 4 decades, we've seen the service array expand. We've seen care come into communities. We've seen support for more individualized approaches. These advances cannot and should not be discounted, but what about the family experience? Why are we having the same conversations, the same experiences 40 years later? It is absolutely not for lack of effort. We're in the rut. And it may be a time for a different approach.
Hey, Carol, I want to just say that we are at time. And
Okay.
so I'm sorry you weren't able to see my messages about they probably didn't come up for you. But I just wanted to see if there was anything as we wrap up that you wanted to say. I didn't just want to end the session.
No, I'm going to end with the same question that I started, and that is, why are family members at the table? And I'll suggest that it's not a question. These are not questions for one person or even for a small group. They're questions that we, as a system of care community, that should be addressing together, locally, regionally, nationally.
Absolutely.
And I appreciate your time. I appreciate your being here, and thank you very much.
Thank you so much, Carol. So much rich information. And I just wanted to also thank everyone for staying in here with us. And I'm going to ask that you would please complete the survey, post presentation survey that you should see in your chat area somewhere. And we wish you a good rest of your day. And you can go back to the schedule to see what's next for you. So thank you again, Carol. Thank you again to everyone in the room and have a good rest of your day.
Thank you.